Hello, I'm Umair Khalid. I'm one of the social media editors at JACC Cardiovascular Interventions, and it's my great pleasure to welcome Dr. Gali for this interview. Thank you so much for joining us today.
Thank you.
So today we will feature your publication titled Genotype-Guided versus Conventional P2Y12 Inhibitors in ACS, a combined analysis of Taylor PCI and popular genetics. So Dr. Gali, what clinical problem motivated this combined analysis of Taylor PCI and popular genetics?
Thank you for your interest in our paper. So basically, the reason why we decided to proceed with this IPD meta-analysis is because of the limitations of individual studies. Because although we have important randomized controlled trials in the field, these trials basically were underpowered for hard endpoints. Mainly because they used non-inferiority design, and also they included both ischemic and bleeding endpoints. So this was the main limitation of this trial, which basically led to too low statistical power for hard endpoints. And another important reason is that we now know that the clinical effectiveness of a guided selection of P2Y12 inhibitors is linked to the fact that we are going to perform a de-escalation of the P2Y12 inhibitor or an escalation. This is because in the escalation, we expect a reduction of thrombotic events potentially without no increase in bleeding, while in the de-escalation strategy, we expect a reduction in bleeding without theoretically an increase in thrombotic event. So we need to assess these outcomes separately for us to be able to capture the real clinical benefit of this strategy. And this is something that we did in this meta-analysis.
Excellent. Thank you so much for your response. That answers my question perfectly. So with that background, could you briefly explain the results of your analysis for the audience, and why do you think genotype guided de-escalation but not escalation drove the clinical benefit?
Yeah, so answering to your last question, so the answer is that in this paper, we only focused in ACS patients. So in these patients where the standard of care is potent P2Y12 inhibition with prasugrel or ticagrelor, we are going to perform a de-escalation in a guided arm, and this is why we expect a reduction in bleeding in the de-escalation arm. So in performing this study, we also added some important novelties compared to individual trials. For example, we excluded patients with concomitant anticoagulations. We excluded patients with stable presentation, and this allowed us to perform a more clean and less biased analysis. Also, the main outcomes were that in the de-escalation arm, which is the most important arm because resemble what we do in clinical practice, because the standard of care in ACS is ticagrelor or prasugrel, so we are more interested in the de-escalation arm. We found that there is a reduction in bleeding assessed with the BARC2 3 or 5 bleeding classification, and also a 23% reduction in NACE. And what is very, very important is that we also performed a landmark analysis in which we have found that most of the effect of this de-escalation is within the first 3 months since ACS. And this is very important because when we compare this strategy to other de-escalation strategies, we know that most of the other de-escalation strategies cannot be started so early at the time of the ACS, like as we did. But usually you have to do a 1 to 3 month standard DAPT, which is a period in which we are not able to reduce bleeding. But because we know that bleeding are highest in the first month after ACS, just like the thrombotic risk is highest in this period, this strategy, the guided strategy, is today the only de-escalation strategy that can help us to reduce bleeding in the period where when it is more useful, from a clinical standpoint. So our landmark analysis is very important on this end.
Absolutely. Thank you so much for going over the results in detail and explaining your perspective as well. There's so much to learn from this paper, and in the future as well, we're always learning about these things. So if the listeners remember just one message from the study, what would you say it would be?
Yeah, so the main message, I think, will be that performing genetic testing in the context of acute coronary syndrome is very easily, has been tested both in randomized controlled trials and in real-world trials. And this is, as I said, the only de-escalation strategy that allows us to reduce bleeding from the very beginning, from the very first weeks. And this is very, very important from a clinical standpoint. I know that in most of the centers, the genotype is not much used, but this is a very easy to do and very fast exam that is supported by strong evidence, because this analysis represents today the highest level of evidence in support of this strategy. So I think people should become more and more familiar with this methodology, which is also very simple and easy to use.
Absolutely. Agree completely. Thank you so much for joining us today, Dr. Gali, and congratulations on your work.
Thank you very much.